Let's start. Okay. A 57-year-old a 57-year-old woman with metastatic breast cancer. A 57-year-old woman with metastatic breast cancer comes to the physician for follow-up examination. She reports that her pain is poorly controlled with her current dose of oral sustained release of morphine. 1 month ago, she repeated the problem, and the doses of the morphine has increased. On examination today, she is agitated and tearful and insists on other increase in morphine doses. Which of the following is the most likely explanation of for this patient's request?
Ready?
Yes.
Inadequate control is the most likely explanation for the patient request. Opioid analgesics are indicated for the management of pain associated with malignancy. Dosage often needs to be increased because of progression of metastatic disease as well as development of opioid tolerance. Tolerance describes the need for an increasing dose of medication to achieve the same effect as prior doses. This occurs as a result of the downregulation of the opioid receptors with recurrent and or prolonged exposure. It is important to recognize that pain caused by cancer is associated with significant limitations in functional status and quality of life. Okay, next.
A 62-year-old a 62-year-old man comes to the physician because of 9-month history of weakness in the left arm. 9-month history of weakness in the left arm and lightheadedness when he plays tennis. His left hand and arm are too cool to touch of these episodes, and his symptoms usually resolve after 15 minutes of rest. He plays tennis 60 minutes 3 times weekly. The episodes occur weekly. He is left-handed. He does not recall any trauma to the left arm and has not had any other symptoms. He smoked 1.5 of the cigarettes daily daily for 27 years, but stopped 10 years ago. He drinks 1 glass of wine daily. His pulse is 78 per minute and regular. Blood pressure is 150 by 88 millimeter of mercury, and right arm is 136 by 70 millimeter of mercury. On the left arm, lungs are clear to auscultation. S1 and S2 are normal. The left radial pulse is decreased. The remainder of the examination, including neurological examination, shows no abnormality. Which of the following is the most appropriate next step?
Ready?
Yes.
So it's MR angiograph. The patient is presenting with signs and symptoms concerning for subclavian still syndrome. Clinical manifestation includes exercise-induced vertigo, lightheadedness, upper extremity fatigue, or asymmetric upper extremity pulses, and impaired perfusion to the affected limb. The underlying pathophysis is a result of stenosis of the subclavian artery proximal to the origin of the vertebral artery, which leads to decreased flow in the distal subclavian artery. Consequently, the affected arm may be perfused through retrograde flow in the ipsilateral vertebral artery, diminishing posterior cerebral circulation and resulting in symptoms of vertebrovascular insufficiency like vertigo, lightheadedness, disequilibrium, ataxia, and nystagmus. The most common cause of subclavian steel syndrome is atherosclerosis. Diagnosis is made by imaging of the arteries of the upper extremities and neck to assess for stenotic lesions and the direction of flow via ultrasound of MR angiogram. Um, Subclavian steel syndrome is a compensatory mechanism that is typically not life-threatening by itself, but instead indicates significant atherosclerosis disease that should be managed with surgical bypass or angioplasty, along with lifestyle changes to prevent further atherosclerosis. Next.
Like how we would diagnose it is subclavian steal syndrome.
Oh, I didn't diagnose it. I just knew it was some kind of claudication, like artery claudication. The only it cannot be anything with the heart. The heart is fine. S1, S2 are normal. The pulse is fine. So there is no chest pain. So nothing with the heart. And then tilt test. I think the tilt test is the one for
Vertigo.
yeah, vertigo. So it's not that. So the only thing that was left was angiography, and we know angiography has to do with arteries and atherosclerosis. That's how I diagnosed it.
Okay. A 35-year-old man, 3-year history of dermatomyositis. He had progressive weakness for 3 weeks. He had previously responded well to high-dose prednisolone therapy. He appears Cushingoid. Serum CK and aldolase activities are now normal. Which of the following is the most uh, uh, which of the following is the most likely diagnosis?
Ready?
Ready?
Mm-hmm. Okay, so it is corticosteroid myopathy. Myopathy is a potential adverse effect of long term steroid use, which is frequently required for treatment of dermatomyositis. Myopathy occurs as a result of the catabolic effect of steroids on muscle. It typically manifests with the progressive onset of proximal muscle weakness, followed by muscle atrophy. Myalgias and muscle tenderness do not typically occur. Muscle tenderness, yeah. Other adverse effects of steroids include cochinoid appearance. Corticosteroid myopathy is associated with inflammation or cellular damage. Thus, creatinine, CK, and aldolase levels are normal. This is in contrast to dermatomyositis, which is caused by inflammatory infiltrate in the muscle, causing myocyte damage, leading to release of intracellular molecules, including CK and aldolase. Active dermatomyocytes will also be expected to show cutaneous features such as pink papules over the Gottron papules, heliotrope sign, light pink to iliac color patches with telangiectasia on upper back and sun exposed chest, like shawl sign, and dilated capillaries with dropout of the proximal nerve folds. Okay. Next.
Okay. A 72-year-old woman is brought to the physician because of increasing clumsiness, restlessness, and confusion over the past 3 weeks. She currently lives with her daughter. She can no longer remember how to make coffee or button her clothes. She has urinary incontinence. Her medication include digoxin, furosemide, potassium, ibuprofen, ranitidine, and diphenhydramine. 1 month ago, she began taking meperidine and rotator cuff injury. Examination showed disorientation, memory loss, and dyspraxia. CT scan of the head show mild cortical atrophy. Which of the following is most which of the following is the appropriate next step in the management?
What is meperidine?
Sorry,
Meperidine, what is it?
is it
What kind of
opioid?
is opioid? Okay.
I think so.
Okay. Mm, 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 mm. Furosemide, ibuprofen, blah blah blah. Diphenhydramine. Mm.
Is it delirium?
But why? Why?
Or is it
Um,
Alzheimer? Or he's sad?
mm, I
Uh, uh,
mm, I don't know, but I don't really know what's the because it is an opioid. So why would it?
she is on fast generation antihistamine. Or is it due to digoxin? Digoxin toxicity. Is there any
That
possibility of digoxin
I,
toxicity?
I don't think so. I thought the ghosting was the GI symptoms. I don't think so.
Is it due to anticholinergic
Mm,
diphenhydramine?
no, we wouldn't put the dyspraxia and the restlessness and all that. I don't know. I really don't know on this one. Okay. Ready? Let's pick the thing.
Okay.
Okay. Let's see. Discontinue. Oh, I guess it was cholinergic. Discontinue anticholinergic medication. Acetylcholine activity in the brain mediates attention and motivation. Anticholinergic agents commonly cause cognitive impairment of delirium. Okay. An acute confused state in elderly patients who possess a decreased cognitive reserve and are therefore one of a number of medications to use with caution in elderly patients. Diphenhydramine is an antihistamine medication used for seasonal allergy and causes anticholinergic adverse effects. Meperidine is a opioid medication used for analgesia that also causes cholinergic effect, anticholinergic effect, along with cognitive impairment leading to this patient disorientation and memory loss. Anticholinergic effects can include sedation, dyspraxia, difficulty of the planning and execution of movement, ataxia, visual disturbance, dry mouth, urinary retention, obvious urinary incontinence, which may lead to overflow incontinence, constipation, and flushing. In this scenario, the subacute onset of cognitive symptoms coincides with the initiation of meperidine. Meperidine and diphenhydramine should be discontinued. Although elderly patients with new onset cognitive impairment should be assessed for reversible causes with throughout history, physical exam, lab testing, neuroimaging, and medication review. It is not within B. Obtaining durable power attorney recommending 24-hour in-home and labeling the drawers should be considered in patients with irreversible cognitive impairment that prevents them from making their own decisions and functioning at home. These patients subacute confusion instead coincides with the addition of an anticholinergic medication and will likely reverse with medication discontinuation. The patient's mild cortical atrophy on CT scan may reflect normal aging. Okay, so meperidine also has anticholinergics. Okay, next.
A 62-year a 62-year-old man is brought to the physician by his wife because of progressive behavioral change over the past 8 weeks. His initial symptoms included anxiety and fatigue that were followed by decreased memory and disorientation. 2 weeks ago, he developed progressive imbalance. 2 weeks ago, he developed progressive imbalance that was progressive imbalance that has progressed to the point where he is unable to walk unassisted. Over the past week, she has had a brief bloody jerk that are precipitated by loud noises. Examination shows disorientation, decreased memory, inability to walk due to mark ataxia, and stimulus-induced myoclonus. An MRI of the brain shows generalized cerebral atrophy. Which of the following is the most likely diagnosis?
Ready?
Yes.
Yes.
Is, is it CGD?
Let me see. Yes. CGD is a human prion disease in which prion proteins replicate throughout the brain and cause neurotoxicity. Patients typically present with neuropsych symptoms like dementia, anxiety, behavioral disturbing deficits, inherited cortical function such as aphasia and apraxia, cerebellar manifestation as ataxia, corticospinal tract dysfunction as spastic weakness, and basal ganglia signs like rigidity, hypokinesia. Stimulus-induced myoclonus is a specific sign of CJD. Over time, the dementia rapidly progresses, invariably leading to death within a year. A probable CGD diagnosis can be made clinically and through CSF analysis, though an autopsy showing spongiform degeneration of the cortex confirms the diagnosis. Treatment is supportive of speed evaluation, education, benzos, or myoclonus. Okay, next.
A 72-year-old woman, sorry, 72-year-old man is brought to the emergency department because of a decreased level of consciousness. For the past 6 hours, 3 days ago, he had fever, shortness of breath, productive cough, fever, shortness of breath, productive cough, treated with antibiotic. But his symptoms did not improve. On arrival, his temperature is 39 degrees Celsius, 102 degree Fahrenheit, pulse 110 per minute, respiration 28 per minute, blood pressure 110 by 75 millimeter of mercury, breath sounder decreased over the right mid-lung field. On neurologic examination, he is arousable but responds to tactile stimuli on moaning, cranial nerves and neck. There is resistance to passiflexion of the neck. Which of the following is the most likely pathogen?
Ready?
Yes.
So it is strep pneumo. These patient signs and symptoms of fever, obtundation, and meningismus with pneumonia are suggestive of bacterial meningitis, which results from bacterial infection and resultant inflammation of the meninges. Surrounding the CNS. Among adults of all ages, staph pneumo and alpha hemolytic gram-positive Staphylococcus is the most common causative pathogen of bacterial meningitis. Less common agents of bacterial meningitis is Neisseria meningitis and Listeria monocytogenes. Findings of bacterial meningitis include fever, altered mental status, headache, meningeal signs such as neck stiffness, and presence of Brudiskin occurring sign. Strep meningitis is commonly distinguished from meningococcal meningitis by the absence of petechial rash. The diagnosis is confirmed through lumbar puncture, demonstrating the presence of bacterial organism and polymorphonuclear cells, a decreased concentration of glucose, and increase of protein in the CSF. Treatment includes supportive therapy and broad spectrum of antibiotics, typically third generation cephalosporin and vancomycin. And vicomycin. The addition of ampicillin to this regimen is necessary If hysteria is suspected as a causative agent, even with appropriate therapy, bacterial meningitis cause substantial mortality. Steroids may be co-administered, which may prevent complications such as resulting cranial nerve dysfunction. It is not the hysteria. The bacillota may cause bacterial meningitis in infants and elderly adults and exhibits characteristic tumbling motility on microscope. It is transmitted through contaminated food such as soft cheese or cold deli meats. It presents with typical signs and symptoms of meningitis. Okay, next.
A 37-year-old woman comes to the physician because she has stumbled several times during the past 4 days. She has also noticed intermittent numbness. She has also noticed intermittent numbness of her left shin and foot. She has no history of serious illness, takes no medication, delivered. She delivered her two children after uncomplicated pregnancies 8 to 10 years ago. Vital signs are within normal limit. Muscle strength 3 by 5, muscle strength 3 by 5, and dorsiflexion of the left foot. Range of motion of the hip. Range of motion of the hip does not produce any symptom. Deep tender reflex are normal. Sensation to pinprick is decreased over the lateral aspect of the left shin. The remainder of the examination shows no abnormality. Which of the following is the most appropriate initial recommendation?
Ready?
Yes.
So it's avoid sitting with crossed legs. Peripheral nerves, particularly in areas that are not protected by surrounding soft tissue, are vulnerable to injury. One such nerve is the peroneal fibular nerve, which provides sensory innervation through its superficial branch to the dorsal foot and lateral shin, and motor innervation through its deep branch to the tibialis anterior muscle. The primary dorsiflexor of the ankle. The peroneal nerve is relatively superficial as it wraps around the lateral aspect of the proximal fibula before dividing into deep and superficial branches. Because of its location, compression of the peroneal nerve potentially occurs when certain positions are kept for a long period of time, such as sitting with crossed legs or lying on a lateral decubitus position on a hard surface. Prolonged compression of the peroneal nerve will potentially cause damage and dysfunction of the nerve, which may manifest as diminished strength in ankle dorsiflexion, as seen in this patient. Sensory loss and paresthesia over the dorsal foot and lateral shin are also present. Treatment is to relieve the source of compression of the nerve, typically by using cushion, cushioning while sleeping or avoiding sitting with crossed legs during the day. During the recovery period, patients should also be given an ankle foot orthosis to keep the foot dorsiflex until motor strength has recovered. Okay, next.
Okay. A, an 82-year-old woman with osteoarthritis. An 82-year-old woman with osteoarthritis is brought to the emergency department because of 4-day history of increasing confusion and progressive generalized wasting. During the past 2 months, she has fallen several times and there was no loss of consciousness. She has had no difficulty sleeping. 2 weeks ago, hydrochlorothiazide and metoclopramide were started for hypertension. Her temperature is 36.7, pulse is 68 per minute, blood pressure 140 by 86. Examination shows right pronator drift. Babinski sign is present on the right. She is drowsy, inattentive to questions, gives several inaccurate answers. Which of the following is explanation of his mental status? Right frontal drift. That means there is an upper motor neuron lesion, isn't it?
Mhm.
Ready?
Mm, Between the infarct or the hematoma, subdural, epidural. If it was subdural, she has hypertension. If it was subdural, there would be like meningitis signs. Falling, blah, blah, blah. Blood pressure is still high. Okay, ready. Ah, subdural hematoma. Head trauma, the use of an oh, because she's been falling. Head trauma, the use of anticoagulants, physical abuse, alcohol use disorder, cerebral atrophy, malignancy are associated with increased rate of developing subdural hematoma. An emerging subdural hematoma appears as a crescent-shaped collection abutting the internal surface epidural subdural. Internal surface of the skull, not bound by suture lines. In some cases, the subdural hematoma may be large enough to compress adjacent brain parenchyma. The displacement of the cerebral hemisphere can result in neurologic deficits, alterment status seizures, herniation syndromes, and signs of increased intracranial pressure. Patients may manifest upper motor neuron examination findings such as spasticity, hyperreflexia, and extensor the Babinski sign. Um, Elderly patients are at risk for cerebral atrophy, which places traction on bridging cortical veins. In this setting, minor trauma such as fall can result in shearing of the veins, leading to hemorrhage. In treated, the subdural hematoma may continue to grow in size. The intracranial compartment is a fixed space within a rigid skull. Pathologic lesions such as subdural hematoma can result in midline shift and herniation and of CNS structure if large enough. When such mass effect is present or when such mass effect is present or at risk of developing surgical intervention such as the compressive burr holes or a craniotomy may be indicated to evacuate the hematoma. It's not the cerebral infarction or stroke can present with sudden change in mental status as well as focal neurologic deficits and upper motor neuron signs. However, symptoms of cerebral infarction are typically acute, not progressive over days, such as in this patient. Patients typically present with acute focal neurologic deficits, especially on one side of the body. It may have speech difficulty, dysarthria, and aphasia. Okay, next.
Yes. A previously healthy 58-year-old man is admitted to the hospital because of 3 episodes of Amarylis fugax in the right eye, 2 episodes of temporary weakness in the left hand and arm for 3 weeks. Which of the following is the most likely cause?
Ready?
Yes.
So it's ulcerative plaque in the of the right internal carotid artery. Amaurosis fugaz describes brief episode of transient unilateral painless vision loss and is indicative of retinal ischemia caused by microembolization of plaque within the ophthalmic artery. Often precedes the onset of central retinal artery occlusion, mm, which is considered an ophthalmic stroke. Amaurosis fugaz should prompt an emergent evaluation for sources of potential emboli, the majority of which originate from the carotid arteries and cardiac valves. These patient amaurosis fugaz and contralateral motor weakness are suggestive of transient ischemic attack affecting the right ophthalmic artery and the primary motor cortex, likely caused by an ulcerative plaque of the right internal carotid artery. Evaluation should include prompt carotid duplex ultrasound as well as echo. Treatment of carotid vascular or cardiac valvular disease can prevent central retinal artery occlusion, which may cause irreversible blindness and stroke. It's not occlusion of the right common carotid artery or left internal carotid artery will cause ischemic stroke rather than transient ischemic attack. Occlusion of the left internal carotid will cause vision on the left eye rather than the right eye. Okay, next.
A previously healthy A previously healthy 18-year-old man is brought to the emergency department because of facial weakness and ear pain. That began this morning. When he awoke this morning, he looked in the mirror and noticed that his face appeared twisted. While he eating breakfast, milk drooled on the left side of the mouth. The ear pain has not relieved by acetaminophen. Examination show weakness of the both upper and lower face of the left. Sensation of the face is normal. Which of the following is the most likely location of this patient's abdomen? Is it Bell's palsy
Mm, don't know. Mm,
or Ramsay?
mm. Oh, he's asking for the location of the
Sorry.
thing. It's asking for the location of the abnormality. The location. Mm, mm. Definitely a nerve or a nerve root. It's definitely the facial nerve. But is it the facial nerve or the facial nerve root? Mm, don't know. Ready?
Yes.
The nerve. An abnormality of the facial nerve is the most likely cause of this patient left facial droop. Involvement of the forehead strongly suggests peripheral nerve injury as opposed to central nerve. So peripheral nerve involves the upper, such as cerebral infarction, which will cause an upper motor neuron pattern of facial weakness, sparing the muscle of the forehead. When complete ipsilateral facial nerve palsy occurs in isolation is known as Bell's palsy, which is thought to most commonly be related to the reactivation of HSV herpes. Though it is often idiopathic, it's typically a benign condition that gradually improves over time. Although treatment with oral steroids and occasionally with acyclovir is indicated in the expedited recovery. Facial nerve, also known as cranial nerve 7, provides motor innervation to the muscles of the face. Parasympathetic innervation to the lacrimal submandibular and sublingual salivary glands, and sensory innervation to the distal part of the tongue, and the external auditory canal. Hmm. Okay, abnormalities of hearing and taste can also occur, but typically improve over time. It is not the nerve root. Nerve root typically describes either the anterior, motor, or dorsal sensory components of spinal nerves. The two roots join to form a spinal nerve that carries both sensory motor fibers to peripheral tissue. In contrast, cranial nerves do not have distinct nerve roots. Oh, got it. Next.
Okay, can we take a 5 minute break?
Yeah.
Okay,
How do you distinct? I have a question. How
yes.
do you have a mnemonic to know that the when it involves the upper face and the lower face is the
Okay, now a 22 year a 22-year college student has 4 year history of severe throbbing generalized headache that occur once weekly. The patient, the headache has preceded by 20 minutes of seeing bright spots. Which of the following is the most effective in reducing the frequency of the patient's headache? Is it migraine headache?
Mhm.
Okay, ready?
Yeah. So it's beta blockers. Migraine is a common condition that presents with recurrent primary headaches. Migraine headaches are typically severe unilateral, throbbing, and associated with nausea, vomiting, photophobia, phonophobia. Pain is usually located behind or adjacent to the eye. Some patients additionally experience an aura before or during the headache, which may present with visual or sensory symptoms such as transient vision loss. Um, hmm? Visual sensory is transient vision loss followed by perception of scintillating shapes or lines and or paresthesia. Migraine triggers include stress, menstruation, weather changes, fasting, and alcohol. Okay, migraines are postulated to arise from deficient serotonin inhibition of the descending pain pathways. Acute migraine treatment includes triptans, serotonin 1B and 1D agonists, and NSAIDs. For patients with disabling or frequent migraine, prophylactic treatment to reduce the frequency of migraine headache is also recommended and includes beta blockers, TCAs, SNRIs, and topiramate and valproate. Okay, next.
Okay. A 60 a 62-year-old man comes to the physician because of right-sided facial pain for 3 days. Right-sided facial pain for 3 days and facial rash for 1 day. She described the pain as burning and uncomfortable feeling in the cheek. She has cold symptoms a week ago that have now resolved. She has hypertension treated with hydrochlorothiazide but is otherwise healthy. She cares for her two grandchildren, ages 1 and 3 years, every weekday after school. Examination shows a vesicular rash over the face. Neurological examination shows no abnormality. Which of the following measure to prevent the transmission to unvaccinated children?
Ready?
Yes.
So is avoid contact with grandma until the rash has resolved. This patient facial rash and vesicular eruption is consistent with the activation of VZV, varicella zoster virus, also known as HHV3, transmitted via direct contact with infected skin lesions or respiratory secretions. VZV causes two diseases, varicella and herpes zoster. Varicella chickenpox occurs in immunocompetent children and is characterized by pruritic asynchronous rash with fluid-filled vesicles that crossed over. It may be transmitted to respiratory secretions or contact with active lesions. Herpes zoster or shingle is caused by recurrence of VZV after it has been reactivated from its dormancy in the dorsal root ganglion of spinal nerve. It most commonly presents as unilateral dermatoma red patch with overlying clear to yellow group vesicles. It can be associated with neuropathic pain, which can both precede and outlast the rash. The thoracic spinal nerves and trigeminal nerve, as in this patient, are particularly common distributions of reactivation. Treatment for herpetic infections, including herpes zoster, infections involve drugs that inhibit viral DNA polymerase, classically guanosine analogs such as acyclovir, valacyclovir, famciclovir, whatever. Prevention of transmission of herpes includes avoiding contact with affected individuals while skin lesions are active or once crusted over, they are no longer infectious. It's not administration of the varicella vaccine to children will not prevent transmission of the virus between family members, but will allow an affected child to quickly mount an antibody response and prevent symptom development. Varicella vaccine is recommended as part of the standard childhood treatment. Okay. I think that was it. Wait, we did C and D. Um, what is the C and D right here? Acyclovir therapy for children is unnecessary as they do not show signs of infection. Prophylactic antiviral treatment is not effective in preventing transmission. Likewise, while acyclovir therapy for the grandmama may hasten the resolution of the skin lesions and decrease the length of time she may transmit the virus, is less effective in preventing transmission than avoiding contact altogether. Got it. Next.
Okay. A 17-year-old girl is brought to the emergency department 30 minutes after striking her forehead on the dashboard in a motor vehicle collision. Examination show lethargy and confusion. CT scan of the head show frontal lobe injury. Which of the following is most likely manifestation of this injury?
Ready?
Yes.
So it is problems with conceptual planning damage. Damage to the frontal lobe typically causes impairment in high order functions such as conceptual planning. The frontal lobe is the largest brain lobe located anterior to the central sulcus and is divided into three general areas: the primary motor cortex, the supplementary and premotor cortices, and the prefrontal cortex. While the former two areas control contralateral motor function, the prefrontal cortex is an associated area unique to humans that mediate motivation, planning, um, goal-oriented behavior, social behavior, and personalities. Damage to the frontal lobes may occur as a result of traumas, cerebrovascular accident, tumors, or neurodegeneration. Patients typically present with A. Motivation, poor judgment and planning, behavioral disinhibition, and personality changes. Management involves correcting the underlying goals. However, deficit may not be fully reversible. It's not B. Ideomotor apraxia refers to inability to execute a motor sequence despite intact motor ability. The left parietal lobe is the most common site of damage. Okay.
So frontal lobe function is mainly planning, goal-oriented behavior, social behavior, personality,
Mm-hmm.
and parietal is lesion in the parietal like agraphia, calculia, finger, agnosia, left to right disorientation, Garsman.
Mm-hmm.
Okay. Prospagnosia is inability to recognize the faces. Happens at, it happens where in the fusiform gyrus.
Mm-hmm.
Fuse, prospagnosia, fuse. Spatial disorientation in the temporal. Okay. The next. Okay.
Okay.
A 57-year-old woman is brought to the physician because of her vague history of tingling in her hands and feet. Tingling in her hands and feet. She says she has had. She says that she has also had decreased sensation in her feet, like I am walking on the sponges, and painless tingling sensation down her back and the legs when she flexes her neck. She has no she has not had weakness or changes in the bowel and bladder. She was diagnosed with stage 3 ovarian cancer 6 months ago and has been treated with intravenous cisplatin and etoposide monthly. She has hypothyroidism treated with levothyroxine. Muscle strength is normal. Deep tendon reflex is absent. Babinski sign is absent. Sensation to the vibration is decreased. In the sensation to the vibration is decreased in the fingertips and absent below the knees. And sensation to the pinprick is decreased in a stocking distribution. Proprioception is decreased in the fingers and the toe. Romberg's sign is present. His gait is slightly wide based. Coordination is normal. Which of the following is the most likely neurologic finding? Is it due to diabetes, peripheral neuropathy?
Where do you see diabetes?
Sorry,
Did they say she has diabetes? Why do you say diabetes? It doesn't. Did they say somewhere that she has
no.
diabetes or like?
Is it due to like drugs or is it MS? My
M-
my
isn't she too old for MS? Probably the drugs. She's feel like she's too old for MS.
MS age distribution is how much? Like
Huh?
when MS can happen?
And MS is only upper motor neuron, right? But here she has upper lower.
Deep tendon reflex are absent.
Yeah, it's not MS. And between toxic and meningeal carcinoma because of
Toxic
whatever.
neuropathy have most likely, I think so.
The meningeal carcinoma because she says something going down the neck, something like that. Right?
Or
Okay.
like flexing his neck. You were
Uh-huh. Uh-huh. That's the first. Okay. Ready? Check.
yes.
So it's toxic neuropathy. Toxic neuropathy secondary to cisplatin therapy is the most likely diagnosis. The stalking global distribution of sensory abnormalities is in addition to loss of lower extremity reflexes and proprioception, with the normal Babinski and normal motor function is diagnostic of peripheral neuropathy. Hmm. While peripheral neuropathy can suggest a wide range of underlying pathologies, including uncontrolled diabetes, amyloidosis, and chronic hepatitis, among others, patients with new onset peripheral neuropathy should always be questioned about exposure to platinum based chemo agents, which exhibit a dose dependent toxic effect on peripheral nerves. Unfortunately, the effect is typically reversible, although some patients may experience gradual improvement of symptoms over many years. Paraneoplastic syndromes, which are commonly seen in small cell lung cancer, can mimic cisplatin induced neuropathy, but this patient does not have a history of small cell lung cancer and does not appear to have any evidence of metastatic malignancy. It is not Meningeal carcinoma refers to metastatic disease that has spread to the meninge, which can occasionally occur with ovarian cancer. Patients typically present with cranial neuropathies, headache, seizures, diplopia. Okay, next.
Okay. A 6-month-old girl is brought to the physician for a follow-up examination after two audiometry screenings showed hearing loss. She was born at term to a 27-year-old primary gravid woman after an uncomplicated pregnancy. Examination of the infant today shows no abnormality. Audiometry today shows significant hearing loss bilaterally. Which of the following is most likely cause of this infant's condition?
Ready?
6 months. Yes.
So it's CMV. CMV infection presents with hearing loss, seizures, petechial rash, intracranial calcifications in the neonate. It is the most common cause of non-hereditary sensorineural hearing loss. In about 10% of cases, hearing loss may be an isolated finding without other or symptoms. Hearing loss is also the most common sequela of an initially asymptomatic neonate. Pregnant women most often contract CMV through exposure from young children. Okay, often to daycare centers. A primary maternal infection has a high risk of vertical transmission via placenta to fetus. Uh, R- eh? An infected fetus may show findings of on ultrasound like periventricular calcification or ventriculomegaly, or may be born prematurely. In adults, CMV causes either asymptomatic infection or mononucleosis-like illness in healthy individuals, and a variety of opportunistic infection in immunocompromised patients. Snuggle bee strep infection is a common cause of neonatal bacteremia meningitis. Pneumonia is acquired as the neonate passes through the birth canal. It does not cause hearing loss. Next.
A 57-year-old woman, sorry, 57-year-old man is brought to the physician by his wife because of constant fatigue for 2 weeks. He has consumed a pint of vodka daily for 30 years. He appears drowsy. His temperature is 37 degrees Celsius, pulse 100 per minute, respiration 20 per minute, blood pressure 120 by 76. Cardiopulmonary examination shows no abnormality. Abdominal examination show severe distension with a fluid web, severe distension of a fluid web. Rectal examination show hemorrhoids. Test of the test of the stool for occult blood is positive. On mental status examination, he responds to questions quickly. When asked to write his name, it is an unintelligible scribble compared with a clear significance on his medical chart for 1 year ago. Uh, Lab studies show hemoglobin 12.5, hematocrit 39%, leukocyte count 7,000 with a normal differential, platelet count 22 2 lakh, prothrombin time is high 18 second, PTT is high, isn't it? On
PT
normal. PT is high. PT is high, it's sure.
normal. PTT is normal.
PTT is normal. Okay. Urea nitrogen 6, creatinine normal, ALT is low. Which of the following is most likely to improve this patient's mental status?
Oh, shit. Did I do this? I did. Ah, dang it. Last time fatigue. Blah blah blah. Improves patient mental status. Okay, ready?
Yes.
So it is administration of lactulose. Administration of oral lactulose is the intervention that is most likely to improve the patient's altered mental status. Occurs Altered mental status occurs frequently in patients with decompensated cirrhosis. While the differential diagnosis is broad and includes systemic infections like UTI, pneumonia, bacteria, blah, 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 bacteria peritonitis, intoxication, hypoxemia, or hypercapnia, among others. And AMS, altered mental status, is frequently the result of hepatic encephalopathy. Hepatic encephalopathy is postulated to result from increased gut generation of ammonia by gram-negative organism coupled with inadequate clearance of this by the cirrhotic liver. Um, oh, computer is about to die. All the clinical findings. Wait, give me a second. Let me move to. Where's my charger? I go to the other bloodstream, and it's readily excreted in the feces. Most patients demonstrate rapid improvement of their mental status after initiation lactulose therapy. Failure to do so should prompt evaluation for alternative causes. It is not if paracentesis should be performed on all patients with ascites and associated fever or abdominal pain who are admitted to the hospital to rule out spontaneous bacterial peritonitis. But it does not have a role in treating underlying hepatic encephalopathy. If SBP, spontaneous bacteria, is discovered, the antibiotics are administered. Additionally, large volume paracentesis can be useful in patients with tense ascites or volume overload. Okay, next.
A 32-year-old woman comes to the physician because of weakness of her right arm and leg. Weakness of her right arm and leg began 1 week ago when she awoke in the morning. 6 days ago, when she took a bath, she noticed that she was unable to feel the heat of the water on the left side of her body. She has a mild upper respiratory She had a mild upper respiratory tract infection 3 weeks ago. Cranial nerves are intact. There is mild weakness of the right upper and the lower extremity. Sensation to the pinprick and the temperature are decreased over the left trunk and left upper and lower extremity. Left trunk and left upper and lower extremity. Sensation to vibration is decreased over the right foot. Reflex in the upper and the lower extremities are more brisk on the right than the left. Babinski sign is present on the right. Which of the following location is most which of the following is the most likely location of this patient's lesion?
Ready?
1 second.
Mhm.
Left. Okay.
So is spinal cord, wait, am I the right? Yeah, spinal cord. Brown sequard syndrome refers to a midsection of the spinal cord, which damages the anterior and dorsal horns along with the three major spinal cord tracts. The corticospinal tract carrying motor fibers, the dorsal column medial lemniscus tract carrying sensory fibers that mediate fine touch for perception, uh, vibration, and pressure, and the spinothalamic tract that carrying sensory fibers that mediate pain and temperature. The corticospinal tract and dorsal column, okay, I'm going to know DCML tract decussate in the medulla. Corticospinal and DCML. Okay. While the spinothalamic tract decussate near the spinal cord level at the peripheral sensory nerve. Okay. Consequently, hemisection of the spinal. You said something?
No, no.
Okay. Consequently, hemisection of the spinal cord leads to ipsilateral lower motor neuron pattern of dysfunction at the level of the lesion and ipsilateral upper motor neuron pattern of dysfunction inferior to the lesion. Further hemisection of the spinal cord results in a ipsilateral impairment of sensation of fine touch. Ipsilateral impairment of sensation of fine touch, pressure, vibration, and proprioception, and a contralateral impairment of sensation of pain and temperature. This patient lesion is likely at the cervical spinal cord level given the dysfunction of both lower and upper extremity. Brown sequence syndrome is most commonly caused by penetrating trauma, but may also be caused by disc herniation, hematoma, or tumor. Treatment depends on the underlying cause, though it's typically focused on physical rehabilitation. It is not brainstem or cerebral hemisphere lesions affecting the three major sensory brainstem and cerebral hemisphere lesion affecting the three major sensory and motor tracts present with contralateral hemisensory deficits and hemiparesis caused by the decussation of all three um, tracts inferior to the lesion. Brainstem lesion also typically cause ipsilateral cranial nerve dysfunction. Makes sense. It is not, what was that? Okay, I think that was the only thing I was thinking about. Okay, next.
Okay. 38. A 72-year-old man comes to the 72-year-old man with 3-year history of Parkinson's disease is brought to the physician by his wife for a follow-up examination. 3 weeks ago, his doses of levodopa-carbidopa was increased. Since then, he has reported seeing people spying on him from across the street. He has no other history of serious medical or psychiatric illness. Takes no other medication. Physical examination shows resting tremor. There is cogwheel rigidity and increased muscle tone. There is cogwheel rigidity, increased muscle tone on mental status examination. He reports seeing people spying on him and says his wife one of them. Addition of which of the following medication is most appropriate next step in the pharmacotherapy?
Ready?
One second.
Okay.
Addition. Okay.
Okay. So it is quetiapine. Carbidopa levodopa increases dopamine concentration in several brain areas. In the basal ganglia, an increased dopamine concentration leads to the improvement of Parkinson's symptoms. In the limbic system, increased dopamine concentration leads to psychotic symptoms. Um, yeah, hallucination and delusions. Distressing psych symptoms in Parkinson's disease are typically managed with antipsychotic medication or a decrease of the dose of carbidopa levodopa. These patients demonstrate residual Parkinson's symptoms that will likely worsen with the decreased dose of carbidopa levodopa. So antipsychotic medication should be given. Typical antipsychotics are cantoperidol, potentially antagonize the dopamine receptor non-selectively across several brain areas, which could lead to worsening of Parkinson's symptoms. A typical antipsychotic like clozapine and quetiapine less potently antagonize dopamine receptors and modulate other neurotransmitters such as serotonin, which assist in regulating dopamine signaling in the limbic system and thus directly address psychotic symptoms. Consequently, a typical antipsychotic improve psychotic symptoms without significant exacerbating the Parkinson. Haloperidol is a yeah, I already read that one. Next. Next.
Yes. A 72-year-old woman is brought to the physician by her son because of 1 month history of progressive forgetfulness. During this period, she has misplaced her keys and checkbook. She forgot that she was supposed to meet him for lunch last week. The patient says she has had progressive fatigue because of recent difficulty staying asleep at night. She often awakens at 4 to 5. She often awakens 4 or 5 a.m. and is unable to fall back asleep. She takes zolpidem once or twice weekly to help her sleep. She has taken it nightly for the past 2 weeks. She has had 4.5 kg weight loss. Says that nothing tastes good anymore. She was 10-year history of esophageal reflux disease treated with lansoprazole and a 2-year history of arthritis treated with acetaminophen. She was an English professor prominent university. 1 year ago, she was required to retire by the university regulation. She maintained an active mm, she maintained an active schedule lecturing and writing for 2 months ago. Her hair is unwashed. She had a mild body odor. She is 168 centimeter tall, weight is 50 kg, BMI is 18 kg per meter square. Her pulse is 72 per minute, blood pressure is 125 by 70. On mental status examination, she appears distracted and worried. She says that her mood is okay, her speech is low and monotone, and she answers with single words. She is alert and oriented to the person, place, and time. Her digit span is forward. Her digit span is six forward to two backward. She can call. She can recall zero of the three objects after 5 minutes. She refuses to perform simple changes calculation or the past precedent. There is which of the following is the most likely diagnosis? Okay,
So it is MDD. MDD explains this patient fatigue, poor sleep, poor appetite, and anhedonia, evidenced by food not tasting the same. Poor concentration, evidenced by decreased digit span and distracted appearance. Psychomotor retardation, low speech. Symptoms of NDD include 2 or more weeks of depressed mood and anhedonia, feelings of guilt and worthlessness, the difficulty concentrating, suicidal thought, and other neurodegenerative symptoms, decreased energy, sleep disturbance, appetite disturbance. These symptoms disrupt everyday functioning as evidenced by this patient poor personal hygiene. Elderly patients may view the neurocognitive symptoms as a manifestation of normal aging, of comorbid or a comorbid medical condition rather than depression. Consequently, depressed elderly patients may struggle to express their depressed mood, though MDD should be suspected in this patient with many other depressive symptoms. MDD in elderly patients can cause pseudodementia, which refers to cognitive impairment secondary to depression, manifesting as this patient's short-term memory difficulties and decreased effort on a brief cognitive screening. Physicians should always inquire about suicidal ideation in patients with MDD. Mood and cognition typically improve with antidepressant medication. It is not adjustment disorder with depressed mood refers to the depressive symptoms beginning within 3 months of a stressor and associated with significant impairment. This timing disorder, commonly known as persistent depressive disorder, refers to depressive mood lasting for 2 years. Both disorders may include allergy, sleep, and appetite changes without meeting the criteria of NDD. It's not Alzheimer is the most common prevalent dementia, presenting with progressive cognitive decline that begins with short-term memory impairment, progresses to apraxia and language abnormalities, and culminates in behavior and personality changes, preventing the patient from performing basic activities of daily living. Alzheimer will not present with this patient constellation of neurovegetative symptoms or this degree of functional impairment after only 1 month of symptoms. It's not substance-induced persistent amnestic disorder refers to anterograde or retrograde memory impairment that persists beyond the expected period of intoxication or withdrawal. This patient illustrates deficits in cognitive domains attention, along with symptoms of depression. Hmm, okay.
okay. A 77-year-old woman with Parkinson's disease is brought to the physician by his wife because of 3-month history of unusual behavior at night. She says that he yells in his sleep and waves his arm as if defended himself. 2 nights ago, he beat her and tried to push her out of the bed. Current medication include carbidopa levodopa. Good job. Examination shows a little facial expression, peel rolling, tremor of both hands, and muscle rigidity. Which of the following is the next step?
What is it? I know it's REM sleep disorder, but how do you diagnose that? Oh no. Anyway, ready?
Okay.
Okay. This polysomnography assists in diagnosing REM sleep behavior disorder. In typical REM sleep, several neural circuits terminate on spinal cord motor neurons to cause sleep apnea. When this muscle atony is low, patients can violently act out their dreams. They typically remember the dreams. REM sleep behavior disorder most commonly occurs in adults, male, and can be idiopathic or related to underlying alpha-synuclein deposition like Parkinson, multiple system, and Lewy body dementia. Polysomnography tracks several sleep-related parameters like brain waves, eye movements, muscle tone, and breathing patterns. Polysomnography showing absent atonia during left sleep confirms the diagnosis. Treatment includes creating a safe sleep environment, and if behavior is severe, initiation melatonin and clonazepam. Patients with idiopathic REM sleep behavior disorder should be closely monitored because of the high rate of developing neurodegenerative disease. It's not multiple sleep latency testing tracks the amount of time it takes the patient to enter REM sleep. A decreased REM sleep latency indicates narcolepsy. The timing of REM sleep is relatively unaffected in patients with REM sleep behavior disorder. And it's not the sleeping and waking EEG may disclose slight abnormalities of slow wave
So,
sleep in patients with REM sleep behavior disorder. However, these abnormalities have not yet been characterized for diagnosis. Next.
a 42-year-old woman is brought to the emergency department by her girlfriend 15 minutes after several episodes of staring and blinking while eating dinner. The patient has history of bipolar disorder well controlled with daily buprenorphine lithium carbonate for the past 5 years. She started taking terbinafine 2 weeks ago for chronic toenail fungus. During the examination, she is convenient. Pulse is 64, respiration 16, blood pressure 140/90. Normal rhythm is heard on cardiac examination. Neurologic examination show no focal finding. Which of the following is the most likely explanation of this patient finding?
Mm, Fine. Ready?
Yes.
Mm. So it is seizure activity. Bupropion is an antidepressant medication sometimes utilized in bipolar disorder for incomplete response to mood stabilizer therapy. That decreases the uptake of norepinephrine and dopamine. By an unknown mechanism, bupropion decreases the seizure threshold. Bupropion is a CYP450 substrate, while terbinafine, an oral antifungal medication utilized for onychomycosis. Okay, so you see, so oral is for onychomycosis and tinea capitis, oral, and the rest is
Topical.
topical. Yeah. Where was I? Bupropion is CYP450 substrate, while terbinafine is a CYP450 inhibitor. Consequently, these patients' bupropion serum concentration were likely increased, okay, by the initiation of terbinafine. Most medication-induced seizures are generalized tonic-clonic seizure, but some are absent seizure. Absent seizure are generalized seizure that cause transient staring episode with impaired consciousness during the seizure. Management involves switching to a topical onychomycosis agent, or a different antidepressant medication that does not cause the seizure. It's not E. Transient
Mhm.
ischemic attack. It's not transient ischemic attack is a transient episode of focal neurologic dysfunction caused by CNS ischemia without infarction. The focal symptoms last less than 24 hours by definition and may last for as little as a few minutes. This patient instead demonstrated generalized bilateral staring and blinking episodes, which are more likely related to generalized seizure. Okay, next.
A 27-year-old man who is HIV positive come to the physician because of left arm clumsiness for a week. His CD4 T lymphocyte is 78. Normal is more than 500. 8 weeks ago. Medication includes zidovudine, diadenosine, zidovudine, diadenosine, ritonavir, azithromycin. He appears with temperature 37.2, pulse 96 per minute, or respiration 16 per minute. Examination showed weakness of the left upper extremity. CT scan of the head with contrast show a re-enhancing lesion in the parietal cortex. Which of the following is the most appropriate next step in the ready?
Mm, So it's oral sulfathiazine and pyrimethamine therapy. Oral sulfathiazine pyrimethamine for the treatment of cerebral toxoplasmosis is the most appropriate next study management. Toxoplasma gondii is an intracellular protozoan parasite. Transmission can occur through ingestion of oocytes from cat feces or infected meat. Direct transmission between mother and fetus or from organ transplantation, which leads to invasion followed by dissemination of the parasite. Um, okay, where it typically lies dormant. It is a ubiquitous organism, and nearly 10% of individuals will be seropositive for toxoplasma, but the parasite does not usually cause severe disease in immunocompetent individuals. In patients with HIV infection and CD4 count less than 100, however, reactivation can occur with several distinct clinical symptoms, of which cerebral toxoplasma is most severe. Cerebral toxoplasmosis typically presents with multiple ring-enhancing lesions scattered throughout the brain, although single cortical lesions are also seen. Seizures, focal neurologic deficits, and systemic symptoms are common. Seizure, okay. The differential diagnosis includes primary central nervous system lymphoma and cerebral abscess. While definitive diagnosis is with brain biopsy that shows a dense infiltrate of lymphocytes, macrophages, and plasma cells, along with presence of toxoplasma organism. This is an invasive and modern procedure. Empiric treatment with sulfadiazine pyrimethamine is favored with close clinical observation. Okay. Failure to improve should prompt a more extensive and potentially invasive diagnostic approach. Cerebral toxoplasmosis is an AIDS-defining illness. It is not intravenous steroid therapy is often given for severe flares of MS requiring hospitalization. While patients with MS may have enhancing lesions on MRI, these are usually multiple periventricular and develop over years. It's not oral TMPSMX therapy. It's typically given as prophylaxis against toxoplasmosis in patients with HIV and CD4 count less than 100. High dose TMPSMX can be used as an alternative treatment for toxoplasmosis, but it's given IV. It's not Brain biopsy may be required if this patient does not respond to empiric therapy. The patient should first be given sulfadiazine and whatever and observe for improvement. If there is no improvement, brain biopsy should be considered to rule out cerebral abscess or primary lymphoma. And it's not lumbar puncture should be avoided in this patient as he has focal neurologic deficit and mass on neuroimaging, which raises suspicion for increased intracranial pressure. Lumbar puncture is the preferred diagnostic for patients with suspected meningitis and meningoencephalitis, not intraparenchymal cerebral disease. Next.
A previously healthy 32-year-old woman has had the acute onset of severe headache, followed by somnolence 2 hours ago. Temperature is 101, pulse 96, blood pressure 140 over 90. Is lethargic but oriented. And answer question appropriately. CT scan of the head shows no abnormality except some small ventricles. CSF color pink, opening pressure 25, glucose 53, protein 85, RBCs present. WBC is 10, segmented level 65, lymphocyte 35%. Which of the following is the most likely diagnosis?
Pink. CSF. Opening pressure is low. Glucose, it is normal. Pink. Oh, why is my thing not working? Okay, my thing not working. And then proteins is high. And RBCs is high. Oh, why is this not working? Oh, white blood cells, blah blah blah. Neutrophils. I think neutrophil is high too. Yeah, it's bacterial. Mm, 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 mm. Mm, it's not encephalopathy. Subarachnoid hemorrhage, idiopathic intracranial hypertension, enterovirus infection, cryptococcal. Oh no. Bum, bum. Ready?
Yes.
Okay. So it is subarachnoid hemorrhage. Subarachnoid hemorrhage, SAH, refers to bleeding into the subarachnoid space. Can be the result of a variety of causes, most commonly trauma, rupture, intracranial aneurysm. Patients typically present with acute severe headache, often described as the worst headache of my life, along with neck stiffness, photophobia, possible stupor or coma. Fever can be associated with the SAH as is associated with worse outcome. CT scan of the head typically shows hyperdense blood products in the cerebral sulci and basal cisterns. However, sensitivity of CT for SAH can be reduced with small volume bleeding or delayed presentation. Okay. If there is continued strong suspicion of SAH following a normal CT scan of the head, a lumbar puncture can be done, which can show red blood cells or xanthochromia, hemoglobin degradation problems, as the blood products circulate within the subarachnoid space. Complications include the development of communicating and obstructive hydrocephalus in the acute stage. In the acute stage. Okay. Along with the potential for rebleeding or vasospasm in the days following the initial bleed. It is a neurosurgical emergency that may be fatal if progressive or untreated. It is not cryptococcal meningitis caused by meningeal infection with Cryptococcus neoformans, which is an encapsulated non-dimorphic yeast and common opportunistic pathogen. In cryptococcal meningitis, lumbar puncture classically detects an increased opening pressure and increased CSF protein, and mononuclear cell pleocytosis. Okay, and it's not, which one was the other one? E. It's not West Nile virus, it's a flavivirus transmitted via the bite of an infected mosquito. It may cause West Nile fever with progression to meningoencephalitis. West Nile fever presents with headache, myalgia, nausea, vomiting, and non-specific maculopapular rash distributed symmetrically on the extremities and trunk. Meningoencephalitis is associated with acute flaccid paralysis, myoclonus, ataxia, and seizures. Okay, next.
A 62-year-old woman, a 62-year-old woman with metastasis of the breast cancer is brought to the emergency department. Because of urinary incontinence. 24 hours. She has metastasis to the skull, multiple vertebral bodies, ribs, liver, para-aortic lymph node. Medication include tamoxifen, sustained morphine, the stool softener, and fluoxetine. Temperature is 36.7. Pulse is 14 per minute. Blood pressure 128 by 76. Examination shows large suprapubic mass. There is decrease. There is significant pain over the entire lumbar spine on fist percussion. Rectal examination shows decreased sphincter tone. Which of the following is the most likely cause of this patient's incontinence? Ready?
Yes. It's metastasis to the cauda equina. Cauda equina syndrome occurs because of compression of the spinal nerve roots comprising the cauda equina. Spinal nerve root, okay. Often such compression occurs as a result of metastasis to the cauda equina, adjacent malignancy, trauma, disc herniation, spinal stenosis, spinal epidural abscess, or spinal epidural subdural hematoma. Symptoms include lower extremity numbness, weakness, paralysis, hyporeflexia, perineal anesthesia, fecal incontinence with poor rectal tone, and overflow incontinence marked by inability to appropriately void and associated urinary retention. Emergent MRI of the lumbosacral spine is indicated to investigate the cause of cardiac equina syndrome and to determine the necessity of surgical decompression. Initial treatment for patients with epidural spinal cord compression and neurologic deficits include symptomatic treatment, pain control, and steroid therapy prior to definite medical or surgical therapy. High dose steroid therapy is helpful as a bridge to definitive therapy as it may transiently improve neurologic function in patients with by decreasing the edema at the site of the cord compression. Next.
A 52-year-old woman is brought A 52-year-old woman is brought to the emergency department by her husband 30 minutes after generalized tonic-clonic seizure. Her husband reports that she has had a headache and has confusion seems confused over the past 3 days. She was scheduled to be evaluated by a pulmonologist. later this week for the onset of mild hemoptysis. She smoked 2 packs of cigarette daily for 30 years. With 5 years ago, she has a 5-year history of type 2 diabetes mellitus controlled by diet. On arrival, she is postic. Her temperature is 37, blood pressure is 110 by 60. She is minimally responsive to the painful stimuli. Cardiopulmonary examination shows no abnormality. There is no peripheral edema. There are no focal neurological deficit. Uh, Sodium very low, 112. Glucose slightly high, 150. Creatinine zero point 0.7, cholesterol 230, osmolarity 238. Serum osmolarity and urine osmolarity. mm, Urine glucose trace protein none, RBC 1 to 3, WBC 1 to 3. Osmolarity, urine osmolarity is 240 milliosmol per kg and sodium is 25. Which of the following is the most likely diagnosis?
Wait, what was the normal osmolarity for urine and serum? I always forgot those.
Normal osmolarity for urine, I think so, 300 to 600 or 400 to 800. 300 to 600, as per I remember.
For the urine and for the serum,
Or normal serum osmolarity is like 275 or approximately 300.
300, 300. So osmolarity here in the urine is, you said 300, so it's low. So it's low. So it cannot be this one. Decrease solid intake. Maybe it's this one. And the nephrotic syndrome, no. Pseudohyponatremia, no. Psychogenic polydipsia, that would be low. But also the other one would also be low. Can also be that. Renal failure is not renal failure. Oh my god, between so many things. Decrease solute intake. Mm,
Ready?
mm,
Hyponatremia and serum osmolarity is less than 275.
decrease
Urine
solute
osmolarity is more than 100.
decrease solute
Urine sodium is less than.
intake. Solute. I'm pretty sure it's not that, but let's see.
What is your
It's
differential?
it's like, oh, I already look at the answer. Sorry, it's SIADH. The answer. Um, we got this one. So small cell. Oh, she was smoking. Small cell lung cancer is a neoplasm associated with numerous paraneoplastic syndromes, including Cushing's syndrome caused by ACTH production, SIADH, myasthenia Lambert-Eaton syndrome, paraneoplastic myelitis, cephalitis, and subacute cerebellar degeneration. These patients are determined status seizure. Confusion are huh? likely to the result of severe hyponatremia secondary to paraneoplastic SIADH in undiagnosed lung cancer. ADH results in increased aquaporin expression on the luminous surface of collecting ducts, which increases the membrane permeability to water, leading to inappropriate free water reabsorption. Hyponatremia decrease Serum osmolarity. Okay, so this was low. Osmolarity was low. Decrease and inappropriate increased urine concentration. So this was high. The urine osmolarity is actually high. Okay, the management of SIDS associated hyponatremia involves treatment of underlying disease, restriction of water intake, and gradual sodium correction. If there are associated severe neurologic symptoms, administration of hypertonic saline may be given to quickly correct the sodium concentration, although this must be performed with caution. So the normal urine osmolarity is probably 100, and this one is probably like the 300 to something that you said. It's not decreased sodium intake will not itself cause hyponatremia as a result of kidneys' ability to reabsorb sodium and water to maintain homeostatic osmolarity. Okay. It's not dehydration fair leads to hypernatremia, no hyponatremia. Okay. And it's not, what was that? Factitious hyponatremia. Let me see how they call it. Factitious hyponatremia caused by hyperglycemia can occur in patients with severe hyperglycemia. This is 150, so it's not enough. And it's not pseudohyponatremia refers to lab error of decreased sodium concentration in the setting of normal serum osmolarity, which can be caused by lipemic serum, obstructive jaundice, or plasma dyscrasia. This patient has decreased osmolarity consistent with with SIADH. It's not excessive water intake of free water in psychogenic polydipsia can result in dilute urine hyponatremia. This patient has inappropriately concentrated urine and low serum osmolarity consistent with SIADH. So normal urine osmolarity is actually 100. Yeah, I got
Okay.
it. Next.
Next,
Sorry. Yeah.
a 3-week-old a 3-week-old newborn is brought to the emergency department by his parents because of one-day history of increased fuzziness. One a history of increased fuzziness and drowsiness en route to emergency department. He had rhythmic jerking movements of all extremities. He had rhythmic jerking movements of all extremities. Her mother had His mother has received minimal prenatal care and was treated for gonococcal cervicitis during pregnancy. Her straight eclampsia status was unknown. He was born at 38 weeks of gestation. Examination at birth showed no abnormality. Today he is irritable, responds only to painful stimulation. His temperature is 39 degrees Celsius, 103 degrees Fahrenheit, pulse 160 per minute, respiration 32 per minute. Examination shows no conjunctivitis or cutaneous lesion. The lungs are clear to auscultation. A lumbar puncture is performed. Glucose 60, protein 100, WBC 300, RBC 5000, grams 10, WBC 2, and there is no organism. In addition to ceftriaxone and vancomycin, which of the following is the most accurate pharmacotherapy? Is it herpes?
Mm, that's the only thing that makes ribavirin is then cyclovir is CMV. Ribavirin is the herpes one. Hepatitis. Zidovudine is the Yeah, probably herpes. Ready?
Yes.
Oh, where is my thing? Okay, this one. Um, it's a cyclovir. Neonatal sepsis is a potentially life-threatening syndrome characterized by severe systemic manifestation of infection in infants less than 28 days of age. The culprit pathogen is most commonly acquired by vertical transmission during transit of the birth canal. Horizontal transmission for contact with healthcare environment is considered early onset neonatal sepsis if the condition developed within 1 week of life and late onset if it's after. Early onset neonatal sepsis is typically caused by Streptococcus E. coli. Common organism implicated in late onset is Streptococcus E. coli, Pseudomonas candida. Initial empirical antimicrobial therapy should cover these bacterial organisms. Lumbar puncture is indicated in the evaluation of natal sepsis as infants do not display typical symptoms of meningitis as associated with adult patients. Empiric coverage for herpes meningoencephalitis with acyclovir should be added to the regimen if the CSF displays an increased red blood cell count or if the patient presents with characteristic herpetic lesions. So they gave him ceftriaxone for I guess E. coli and vancomycin and Runova for Staph aureus. Okay.
Next. An otherwise healthy 62-year-old man is brought to the emergency department 45 minutes after an episode 45 minutes after an episode of loss of consciousness while shaving. Prior to the episode, he has a lightheadedness, nausea, and dimming of the vision. His wife states that he was unconscious for 1 minute, lost control of the bladder function. He did not notice any movement during this episode. He has similar episode 1 month ago while shaving. At that time, electrocardiography 24-hour till test show no abnormal cardiac enzyme normal. Current blood pressure is 150/96. A grade 2/6. Systolic ejection murmur is heard at the upper left sternal border. The remainder of the examination show no abnormality. Which of the following is the most likely diagnosis?
Ready?
Yes.
So is carotid sinus hypersensitivity. Carotid sinus hypersensitivity syndrome is characterized by exaggerated response to carotid baroreceptor stimulation with the resultant sinus bradycardia hypotension and syncope. Baroreceptors located at the carotid bifurcations and the aortic arch are important in regulating cardiac output and maintaining adequate perfusion pressures to the brain and organs of the upper body. Baroreceptors are sensitive to mechanical pressure. Normally, an increase in blood pressure stimulates baroreceptor activity, which activates a reflex arc. This results in parasympathetic innervation of the sinoatrial and AV nodes and inhibition of sympathetic vascular tone. In turn, this causes decreased pulse and peripheral vascular resistance. Mechanical compression of the baroreceptors from external palpation, such as during shaving of the neck, can potentially stimulate this reflex. It is not a vasovagal syncope. Neurocardiogenic or vasovagal syncope is a common cause of syncope, often associated with nausea, lightheadedness, visual disturbance, pallor, and no diaphoresis. Symptoms usually occur after standing for a prolonged period. Normal TIL test in this patient makes this diagnosis less likely than carotid sinus. Thing. Hmm. Okay.
Next, a 100-year-old man is brought to the physician because of 10-month history of difficulty walking and decreased grip strength and stiffness of the hands and interfering with his job. As a plumber, he has no history of serious illness. There is frontal balding, cranial nerve examination show bilateral ptosis, cranial nerve exam bilateral ptosis and atrophy of the sternocleidomastoid and the temporalis muscle. There is distal intrinsic musculature weakness of the hands and bilateral weakness of the on the ankle dorsiflexion. Percussion of the hypothenar results in slow relaxation. The sensation is intact. Which of the following is the most likely diagnosis? Okay, ready?
Mm, yeah, it is myotonic dystrophy. Oof. Myotonic dystrophy is a genetic disorder caused by expansion of trinuclear repeat, which occurs when a series of three nucleotides in repetition are replicated incorrectly, and too many repeats are included in the replicated product. Other conditions caused by trinuclear repeat expansion include Fragile X syndrome, which is CGG. Correct
So,
me if I'm wrong.
sorry,
Fragile, Fragile X syndrome is
CGG.
the CGG. And then Huntington, which is CAG, CAG.
G. Yes.
Okay. And then Frederick ataxia, I forgot that one. CTG?
No. Frederick
Ah,
ataxia is gait. Ataxia gait. GAA.
oh, yeah, GAA. Was close. Myotonic dystrophy has several
And
phenotypes, but
myotonic dystrophy is CTG.
oh, it's the front of
Cataract,
CT.
2P, and gonadal atrophy.
Cataract and gonadal atrophy. Cataract. But all are characterized by muscle weakness and myotonia, defined as delayed relaxation following a normal contraction of the muscle. Classic myotonic dystrophy, as seen in this patient, presents during the second, third, or fourth decades of life with muscle weakness, myotonia, cataracts, frontal balding, cardiac arrhythmias, and hypogonadism. The most frequently affected muscles include facial muscles, sternocleidomastoid, um, facial muscle of distal forearm muscles, intrinsic hand muscles, and ankle dorsiflexors. Life expectancy is slightly reduced for patients with classic myotonic dystrophy, and premature death is most commonly caused by respiratory or cardiac dysfunction. It's not facioscapulohumeral muscular dystrophy. It's a type of muscular dystrophy in which progressive muscle weakness of the facial, scapula, and upper arms, lower legs, and hip girders occur. The muscles are commonly involved in an asymmetric pattern and it typically presents by age 20 years. And it's not, I was there, yeah, Myasthenia gravis, autoimmune disorder that commonly presents with ptosis, diplopia, dysphagia, and muscle weakness, which are words with repetitive. No, that's not that. Spinal muscle atrophy is a group of autosomal recessive disorder that lead to degeneration of mo- motoneurons, and result in progressive hypotonia and areflexia. Patients may exhibit difficulty with mobility and frequently experience respiratory distress and difficulty feeding. Okay.
Next,
Mhm.
a 57-year-old woman comes to the physician because of persistent numbness of his back and her right hand for 2 weeks. Her symptoms began after operative treatment of distal radial fracture. Sensation to the pinprick is decreased over the dorsal past with thumb, index finger. There is no motor deficit. Which of the following is the most likely site of the injury? Ready?
One moment. Sensation making the of a dorsal first web thumb index finger. There is no motor deficit which is the following site of injury. Say the thumb and index finger. Mm, and then near the distal forearm, radial nerve above the elbow, radial nerve at the elbow, distal forearm. Okay, sorry, ready. Mm, mm, mm.
Okay.
So it is. Oh, what's happening? Radial nerve at the distal forearm. Distal radius fractures are more common orthopedic injury, often caused by fall onto the outstretched hand. Treatment of distal radius fractures can be non-operative with a splint or cast immobilization, or can involve an operation with percutaneous spinning or fixation with plating. Distal fractures, radius fractures may be complicated by median nerve injury, acute carpal tunnel syndrome, while operative management can be complicated by injury to the superficial radial nerve in the wrist. The median nerve supplies sensation to the volar and dorsal distal aspects of the lateral 3.5 fingers and lateral palm of the hand, thenar eminence, whereas the radial nerve supplies sensation to the dorsal faces of the lateral 3.5 fingers and the lateral dorsum of the hand. This patient has impaired sensation around the dorsum of the hand, consistent with radial nerve injury at the wrist, and it's not ing. What is it? This one. Radial nerve can be injured above the elbow as a result of compression at the axilla from using crutches, or sleeping with the arm over the chair. Injury to the radial nerve above or at the elbow will result in loss of elbow and wrist extension, as well as loss of sensation over the posterior forearm and dorsal hand. This patient only has symptoms in the hand. Okay, next.
I don't understand this answer. Like, can you describe how you find out the answer?
If it's they're saying that if it's at the hand, if the injury is at just at the hand, then
Yes.
you will just have problems in the fingers. So at the hand, but if the injury is at the elbow, above the elbow, you will have injuries. You will have problems at the hand and also in the forearm. Does it make sense?
Okay.
Well, does it make sense, or you just saying okay to say okay?
I'm not finding clue like how to deal this.
Okay, so this one here it says symptoms after the operation. Don't worry about that. It says
Okay.
numbness,
But
numbness.
my query is
Mhm.
sensation to pinprick is decreased over the dorsal Fast web, thumb, and index finger. Isn't it the medial nerve distribution?
No, that's what they're saying. Dorsal, dorsal does means not at the palm.
Okay.
The
Oh, sorry.
dorsal means yeah. So if it was at the palm, yes, it's the median nerve. But it said dorsal, so the back.
Dorsal. So back. So it is
Mm,
radial nerve distribution.
it's
Okay.
medial nerve.
Now,
Mhm.
now the why the distal forearm?
The distal forearm just means that it probably the damage of the radial nerve was at the wrist or like it wasn't at the elbow. So it can either be damaged at the elbow or at the wrist. And they're saying that it's probably at the wrist, it's not at the elbow. Because if it was at the elbow, then you will also have loss of sensation in the forearm, in the back of the dorsal aspect of the forearm. Does it make
Okay, that makes sense now.
sense? Yeah.
Sensation to uh, which of the following is the most likely diagnosis? Sensation to prick is decreased below the T4 level. Okay, can you tell me the diagnosis?
Oh, no. That's it. It's just no. Cannot tell you.
Okay,
I know T4 is. Uh-huh.
okay. I'm reading the whole question. Okay. A 62-year-old woman is brought to the emergency department because of 3-day history of progressive weakness and numbness. These symptoms first occur in the feet and have a spread to include the chest. She has also difficulty emptying bladder completely. She has moderate mild back pain that began 1 month ago, now radiates to her chest. It is exacerbated when he coughed 1 year ago. She has a breast cancer under lumpectomy, followed by radiation and chemo. Her only medication is tamoxifen. Vital signs are normal limit, muscle strength 5 by 5, upper extremity 4 by 5 in the lower extremity. With increased tone, deep tendon reflex at 2 plus in the upper extremity, 4 plus in the lower extremity. Babinski sign is present bilaterally. Sensation to pinprick is decreased below the T4 level. Which of the following is the most likely diagnosis? Okay, what is your diagnosis?
No, I'm between epidural cord compression, paraneoplastic myelopathy, and transverse myelitis. Transverse myelitis is MS, and she's pretty old for MS. Mm, 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 mm. Transverse myelitis will be, yeah, I feel like it's pretty old for MS. Myelopathy, maybe myelopathy. Mm, I don't know. I'm between AD and E. Probably A. Epidural cord compression. Mm, I'll go with that, but I'm not sure. Ready?
Yes.
Mm-mm. It's epidural cord compression. That was a good guess. Spinal cord compression can occur because of malignancy, trauma, dissemination, spinal stenosis, spinal epidural abscess, spinal epidural hematoma. Neurologic symptoms depend on the site of spinal cord compression, with sensation and motor deficits below the level of the lesion. Patients may manifest open motor neuron examination findings such as spasticity, hyperreflexia, Babinski sign. Initial treatment for patients with epidural spinal cord compression and neurologic deficits include symptomatic treatment, pain control, steroid therapy. I think we already read that. It's not DNE. What is it? Paraneoplastic myelopathy can occur in malignancy and present with progressive spastic paresis. and can be associated with encephalitis, sensory neuropathy, optic neuropathy, and chorea. Never heard that. Transverse myelitis is caused by inflammation across both sides of one segment of the spinal cord. All sensory and motor pathways are either partially or completely interrupted. Like spinal cord compression, there is often motor loss and diminished sensation in all dermatomes below the level of the lesion. Transverse myelitis can be idiopathic and can be, in some cases, follow an antecedent respiratory or GI illness. It has also been associated with MS and SLE. Okay. Wait, how did you know from just reading the sensation pain decrease below T4 that that was the
Okay.
answer?
Uh, I have two differential. It is not GBS. GBS has lower motor neuron type of paralysis, isn't it?
Mm-hmm.
It would be either spinal cord compression or transverse myelitis, where there is definitive sensory level in transverse myelitis. Okay, possibility of cord compression is higher, like spinal cord compression can be compressive and non-compressive. We know that. Probability of compressive in here is much more, and mm, there is upper motor neuron sign jerk, or everything is exaggerated. I was initially thinking the definite sensory level, but it is sensation to pinprick decrease to the below the T4 level. It is not definitive sensory level, so that's why it is not TM. So we should think about epidural cord compression, because a cord compression can come with upper motor neuron features, UMN features,
Mm-hmm.
isn't it? And
Mm-hmm.
in cord compression, there is another thing like sensation will be diminished, sensation will be involved. But if it is not cord compression, like if it is like uh, upper motor neuron type of lesion like stroke, then sensory will be intact.
Mm.
Okay,
Okay, we are done.
done.
Okay, do you want to do by start or you want to do it tomorrow?
No, today we can stop by start.
We can stop.
My head
Okay,
is not working.
it's okay. I'll see you tomorrow.
Okay.
Bye bye.
Let's start. Okay.